Thank you very much, and thank you the organizing committee for inviting me to BRONCHUS. And my topic today is the management of endobronchial TB stenosis. As you may all aware that it is the common problem in the patient in the TB endemic area, and it occurs 15% by rigid bronchoscopy, 40% by autopsy, and 54% by flexible bronchoscopy. It occurs female, much more female than male, and it occurs second to third decade of life. The location of the stenosis occur in lobar more than main bronchus, and then segmental bronchus, and the trachea is the least common place. In terms of the bronchoscopic assessment, Dr. Chung report the 7 types of endobronchial stenosis that start from the actively caseating to the non-specific bronchitis. And those are 7 types. It does not have to be A to B to C. It can occur in any types. Why is important? Because of the actively caseating and edematous hyperemic types are those 2 types that tend to proceed to the endobronchial TB stenosis. Apart from that is the female sex, symptoms more than 4 weeks, and no history of pulmonary TB. Those are also the predictor of endobronchial TB stenosis. In terms of evaluation, the radial endobronchial ultrasound can be used, and this type of radial endobronchial ultrasound is not the radial probe that we use, it's actually the probe that used with the balloon. And we can see that there's a cartilage here, which is thick and healthy. And compared to this case, the cartilage is very thin. So with this evaluation, we can define into the preserved cartilage and the destroyed cartilage. In the case with the destroyed cartilage, after the balloon dilation, laser, and the mechanical dilation, the chance that the airway will collapse, not only because of the restenosis, but also with the malacia, because of the lack of the cartilage structure, occurs, and those patients tend to need the bronchial stent or tracheal stent. In terms of the management of endobronchial TB stenosis consists of the anti-tuberculosis drugs, bronchoscopic intervention, and other modalities, and the last thing is surgical resection. The anti-tuberculosis alone is also effective in terms of reducing the bronchial stenosis, and this study around almost 20 years ago, that after the treatment of anti-tuberculosis, the patient who has grade 2 or grade 3 luminal narrowing remains stable or reduced to grade 1 around 60 to 80%. But note that the patient who has grade 1 disease or mild disease, bronchostenosis, after the treatment, around 19% will increase to grade 2 or grade 3 disease. The medication alone is not enough for the endobronchial TB stenosis in terms of the tracheal involvement, especially in the patient with severe tracheal stenosis. In those cases, then the bronchoscopic intervention comes, and that includes the mechanical dilation. You can use either Bucci or use the rigid bronchoscope to dilate the stenosis part, and with the balloon dilation, laser, cryotherapy. You can also use the microdebrider. And the stent insertion is mostly required if the cartilage is destroyed. In general, we use the multi-modalities combined with all the procedure interventions. Like in this case, we use the laser to cut the stenosis, the fibrosis part first, and then we use the balloon dilation and the rigid and put the stent in. In terms of the silicone stent, it was studied in Korea. There are 80 patients who basically has a tracheobronchial stenosis, and the disease is mainly in the left main bronchus, then the trachea, and the right main bronchus. The average luminal narrowing of the trachea is 9.5 centimeter, and the main bronchus is 5 millimeters. Total of 80 patients underwent the rigid bronchoscopy, and then 51 patients end up stenting after all the intervention, which is the mechanical dilation, ND-YAG laser, ballooning. 29 patients survived without the stenting. But 24 out of 25 patients basically require stenting after the third recurrence of stenosis, so total of 75 patients. After putting the stent for a year or so, then the stent was removed in 54 patients, and 49 patients remain stent-free. But 5 patients require restenting again. So total at the end is 23 patients require long-term stenting, and 3 patients require surgical resection. In terms of outcomes, the patient immediately improved in 70 patients, 88%, and the mean duration of the stent placement is 14 months. If you can see in the graph here that the longer the stent press, then the chance that have the restenosis occur is less. In this graph, if the stent is put only less than 12 months, the restenosis rate is occur around 35% compared to 8% between 12 to 18 months and 0% if the stent is pressed more than 18 months. This is an example case that we see and in our hospital. She's an 18-year-old female who basically air transported from Burma because she has severe tracheal stenosis. The average length, luminal diameter is 3 to 5 millimeters, and the extension, it starts from 2.5 centimeter below the vocal cords to 2 centimeter above the carina. So total around 8-9 centimeter in length. She also has the right main bronchial stenosis with 3 millimeter luminal diameter. And this is her CT scan. Let's see if it works. Okay, so this the stenosis start here and then all the way down to the carina. I'm going to stop it. It takes a lot of time. By the time she arrives, our hospital, she has in the respiratory failure, and actually the intubation is not helpful for her because of the severe stenosis part that occur. So basically, in this case, we end up save her life first. We put her in the veno-venous ECMO. So in this case, once she's on the ECMO, the oxygenation and ventilation will not be the issue. And we put the rigid bronchoscopy in, and we slowly laser the stenosis part with the balloon dilation, and then mechanical dilation with the rigid bronchoscopy. So we slowly repeat these procedures until we arrive the carina here, and you can see that the right main bronchus was stenosed around 3 centimeters. So we again laser and balloon dilate the right main bronchus. And we end up put the tracheal stent in because at that time the right main bronchus so is still stenosis even though it's dilated. But she did well and she was discharged. Actually, I end up write the recommendation for her to apply the university in Thailand, so she doesn't have to go back to Myanmar back and forth for follow-up. So she can follow up with me easily because we put the stent in, so we're not sure that the complication may occur or not in any time. And this is another example of a 38-year-old female who has long-standing severe tracheal stenosis, more than 20 years. She came to our hospital, and we did the same procedure, the rigid bronchoscopy, and the YAG laser and balloon dilation, and then mechanical dilation, slowly doing it. But in this case, because of the long-standing tracheal stenosis, then we dilate up to 9 millimeters, then the trachea was so thin, very thin to the point that we can see the pulsate time from the aorta transmitted to the tracheal wall. So we basically stopped the dilation, and then she came back with the re-stenosis, and then we repeat the procedure again. So finally, we basically asked our engineering lab to make the silicone stent is from the medical grade silicone with the 9 millimeter tracheal diameter and 8 millimeter bronchial diameter, just put it in. We cut it first and then put it through the rigid bronchoscopy. It's not the perfect stent, but it saved her life, and she still needs the follow-up bronchoscopy for the cleaning and the abrasion of the granulation tissue. In terms of the cryotherapy, there is evidence to treat granular type endobronchial tuberculosis, and this is a study in China, analysis of 38 cases. So basically, they use the 2.8 millimeter cryoprobe and abrade with the 1 minute freezing time, abrade all the granular endobronchial tuberculosis. So basically, they repeat the procedure every 2 weeks until the granular endobronchial tuberculosis resolved. And in this study, basically, the cryotherapy group with the anti-tuberculosis showed that those patients resulted in the faster improvement and also a faster disappear of the granular endobronchial tuberculosis compared to the medication alone. And 9 patients in the medication alone needs cryotherapy. In terms of the other treatment that may benefit is mitomycin C, the local corticosteroid, and brachytherapy. Those are in the case reports. The surgical resection is also the option for the patient who has a short segment stenosis. So basically, they resect the segment and re-anastomosis the trachea or the bronchus. In the analysis of 36 cases, the mortality is 5.6%. And that was 30 years ago in Japan. So basically, nowadays the mortality is much less. The problem with the surgical resection is the re-stenosis at the anastomosis site, which is occur around 20%. So that comes to intervention again. So that's my talk, and I would like to, again, to thank you, the organizing committee, and I would like to finish my talk.